Well, thank you, Vicki, and everybody on the organizing committee to get us together this morning. And I welcome all the participants. I can see we have over 50 individuals from our 4 states and hopefully even beyond our 4 states border this morning. It really is an honor to be with you today to really talk about sort of the heart of hearts. 2 weeks ago, we had our introductory lecture regarding the heart's overview of the program, and we touched on some of the aspects we're going to talk about today. But now we're going to really get down to the grassroots. And really what I want to talk to you about for the next 25 to 30 minutes really is the critical component of hearts. Obviously, the whole package is important. But if we're going to start somewhere, let's start with a standardized, simple pharmacologic treatment protocol, how one is considered, how it's developed, and why it's such a critical component for increasing hypertension control rates. This has been in use now for over 10 years in our Hearts in Americas and now our Global Hearts Initiative, and we're already starting to see early significant results. And we're going to talk a little bit about that. Vicki, next slide, please. Well, first of all, what we're really going to talk about today, and I mentioned this again 2 weeks ago, is we're going to talk about change. And change is hard. Change at an institutional level is hard. I think change at an individual level is even harder. But a gentleman by the name of Cotter in the 1980s really looked at institutional change when things were going well, but yet there were storm clouds on the horizon. And what are some of the key steps for an organization and the individuals within that organization to change? And the number one step that Cotter proposed to any of us embark upon when we're thinking about change is that we must establish a sense of urgency, a so-called burning platform. Well, what is our sense of urgency and burning platform to have our discussion today when we're going to be discussing change, individual and organizational change? Well, clearly it's on this slide, and we all know this slide. First of all, non-communicable diseases, particularly cardiovascular disease led by hypertension, is now the leading cause of morbidity and mortality globally, including in our 4 states, in my home state, South Carolina. It is the leading risk factor for cardiovascular disease. Unfortunately, if we look at hypertension control rates globally, and we're going to hone down into our own country, they're dismal. Recently in the Lancet last year, it was reported that hypertension control rates, as defined by a blood pressure of greater than 140 over 90 millimeters of mercury, are only about 20%. That's really particularly disturbing when we know, even worldwide, there are safe, effective, and affordable pharmacologic treatment agents for hypertension, and they're available. What do we really need to do? Well, given this burning platform, we really have to start honest discussions on how our current practices have not been successful, including, as we're going to see on the next slide, in the United States. And that should lead us to examine opportunities to increase the control rates for hypertension, even if it makes us do some introspection for change. Again, I'll reemphasize that at an individual and systems level. And again, we've heard this since many, many years now. The definition of insanity is doing the same thing over and over again and expecting different results. Let's do something different. And what I'm going to propose today is one component of the Hearts technical package that is the key, the heart of hearts, if you will, for us to get started on that change journey. Next slide. Well, that was the burning platform globally. Well, what's the burning platform nationally and in our individual states? And it's in this slide. Our national data that examines hypertension control rates comes from the NHANES data set. They're published periodically on many disease states, not just hypertension. Until the NHANES report in 2013 to 2014, we thought we were pretty okay. Our hypertension control rates continually increased, albeit very gradually, but they were increasing. They reached a peak of about 54% in that survey of 2014. However, we were in for a real jolt when the later NHANES report came out in 2017 to 2018, and for the first time in our history of tracking hypertension control rates, in fact, our hypertension control rates did not increase. In fact, they significantly decreased to about 44%. And remember, this is pre-COVID, so we cannot blame the COVID pandemic on these results. And there's only been a small increase in the latest survey, which basically is not clinically significant. So that is our burning platform. That's if we use 140/90 as the definition. Some organizations, such as our organizations, the American College of Cardiology and the American Heart Association, have criteria that define hypertension as 130/80 or greater. If we use that criteria, our hypertension control rates are only 19%. This data prompted our Surgeon General to actually issue a call for action in 2020. Now, this call for action was in the height of the pandemic, of our COVID pandemic. And he felt this data was so significant and so disturbing that in 2020, the Surgeon General issued a call for action to increase our hypertension awareness and increase our hypertension control rates nationally. And the core framework of the Surgeon General's implementation steps, if you will, was to start with a standardized program and initial combination pharmacologic treatment once the hypertensive patient is diagnosed. Next slide. So what we are talking about in terms of change is sort of this timeline. Even in my life, we started with no care for the hypertensive individual for two very good reasons. Number one, we did not have evidence-based medicine that demonstrated that lowering blood pressure, however we were to do that, would result in clinical outcomes. And we didn't have very tolerable and effective antihypertensive agents anyway. However, with new data, obviously the data showing reducing blood pressure dramatically improves cardiovascular morbidity and mortality, we embarked upon a step care approach, which the cornerstone was one medication, a diuretic for everybody, titrate the dose to maximal doses. If the blood pressure is still not controlled, add a second agent, titrate it to maximal doses, and so forth and so forth. This gave way to an individualized care approach where basically it was step care, but now you could start with one of several different classes of antihypertensive agents as the first initial step. But still, the step care approach was in place. One medication, maximize the dose, add a second, maximize the dose, etc. I think it's clearly time now for change. And that is to take a population-based approach or a population-based care approach. And we're going to discuss that as part of the HEARTS package, but specifically the standardized protocol. Next slide. Well, what are some of the barriers that have again, blockaded our ability to increase hypertension control rates to 80, 90% and beyond? They're shown on this slide. Clearly, there's more than this, but there are patient barriers, there's healthcare provider barriers, and there's health system barriers. I highlighted on this slide some of the areas where initiating a standardized formulary and a simple treatment protocol, which is the component of the E module of the HEARTS technical package, directly addresses. Number one, it directly addresses poor adherence to treatment. It directly addresses therapeutic or clinical inertia. Poor adherence to treatment guidelines because it's simple. And on a health system level, it helps with supply distribution, cost of medications, supply chain, if you will, and it simplifies complex medical regimens. Next slide. Well, this is the HEARTS technical package. There are 6 modules following the HEARTS acronym, if you will: healthy lifestyles, evidence-based protocols, access to medicines, risk-based cardiovascular management, team-based care, and of course, you have to monitor things, so systems for monitoring. What really we're going to talk about is the heart of HEARTS, which is the E module, the evidence-based protocol module. That's where you'll find the material for today. Next slide. Well, let's talk about one of the primary barriers, which I think is actually probably one of the most important clinical barriers to achieving hypertension control. And that's on us. That's on our individual shoulders, if you will. And that is clinical or therapeutic inertia. We all know what it is. It's the failure of healthcare professionals, physicians, to initiate or intensify treatment when clearly it's indicated. And everybody would agree that, according to evidence-based medicine, that intensification or initiation of treatment is indicated. But we don't do it. Next slide. And this is one of the most dramatic data pieces I've ever seen. And that shows one of the reasons why. It's sort of human in nature. This is on the x-axis is baseline systolic blood pressure. And the percentages, as you see, are the percentages of individuals with that level of blood pressure that left the office visit without medication intensification or initiation. If the systolic blood pressure was greater than 180, 55% of individuals left without medication intensification. That's bad enough, but it gets worse. As the systolic blood pressure gradually is lowered and comes closer to control rates, the percentage of individuals that leave without medication initiation or intensification dramatically increases. So far as if the blood pressure is between 150 to 160, 87% of individuals left without intensification. That means only 13% had their blood pressure medications initiated and or dosages increased. That is really, really interesting. Remember that 87%. Next slide. Well, what I've heard and what I hear in South Carolina is that's somewhere else. That's not us. We don't do that. But yes, we do. This is data from the Hypertension Initiative in South Carolina and also North Carolina and parts of Georgia, demonstrating the therapeutic effect of clinical or therapeutic inertia in South Carolina. In yellow, the graph shows are individuals that had their medications not intensified. In other words, they had therapeutic inertia. The red are the individuals that had their medications initiated or intensified, shown in red. And as you can see, individuals that had their medications intensified, shown in red, the systolic blood pressures were 126/74, compared to those that had experienced therapeutic inertia. But more importantly, look at the blood pressure control rates. Simply achieving and overcoming therapeutic inertia increased hypertension control rates to 78% in South Carolina. But also in the words on the left-hand side, you'll see at the very bottom that therapeutic inertia occurred in 87% of visits in our three-state region, particularly in South Carolina. Exactly the same as the data we just reviewed. So this one is on us. This falls on our shoulders. Next slide. So what about the hypertension treatment algorithm or protocol? Why is it so important? It's important because it is the key to a population-based public health and, most importantly, primary care approach to treating individuals with hypertension and achieving population-based hypertension control augmentation. Why? Well, number one, it's a critical strategy to increase hypertension control rates, as we're going to see. It specifically addresses clinical or therapeutic inertia because it gives us a guide. It tells us to increase or initiate antihypertensive medication treatment. It has to do so because it's simple, straightforward, and standardized. We will talk about that. And importantly, it can be adopted locally at a clinic level, a system level, a state, countrywide, or even some of us are even imagining globally. And there are some guiding principles, though, regarding the hypertension treatment protocol. Number one, and again, I'm going to say this over and over again, it must be primary care based. That is where we're seeing our hypertension population. That is where we're going to achieve our hypertension control rates. There's always the need for our subspecialty colleagues. But that gets us down to the next step, which is the algorithm is for the patient rule, not the exception. We can always think of the patient exception, but the algorithm or treatment protocol is for the patient rule, the 80 to 85% of individuals where it dramatically benefits. We always have to individualize care and work with our specialty colleagues when those individuals are delineated, but they are fewer and far between. It must have few medication titration steps as possible, and it needs to be linear. By that, I mean no branch points. We've always seen treatment protocols or algorithms with arrows going in every different direction. This one needs to be straight, linear, and simple, and you're going to see some examples. And 2 key points. The algorithm must start with half maximal effective doses of the selected antihypertensive agent. Doing so requires only then 1 treatment titration step to achieve maximal doses, and 2 medications initiated upon the diagnosis of hypertension is also a must for initial treatment, either as 2 separate pills, or even better yet, where possible, a fixed dose or single pill combination. But again, even when we're starting 2 medications at once, they must be at half maximal dosages. That way we only have 1 titration step to achieve maximal dose. And then of course we can add further antihypertensive medications when warranted. Next slide. So what are some of the advantages of using 2 medications at once, as I've already said? Well, number 1, almost all of our hypertension individuals, particularly as our guidelines lower and lower our target blood pressure, are going to need at least 2 antihypertensive medications. So why not start with 2? When we use 2 medications in combination from complementary classes, there's greater efficacy, either additive or even better yet, synergistic effects to lower blood pressure. And this is important. Using 2 medications at half maximal doses of each achieves reduced side effects. And if we pick the right classes as complementary classes, they mitigate the side effects of each other. And it's more effective than using the maximal dose of either single agent. So why not start? It also is a simplified treatment regimen. It clearly results in better adherence. The data is clear. It reduces clinical inertia because it's a guide. It tells us when and how to do it, or reminds us when and how to do it. And this is, I think, the most important thing if we're talking about a population-based approach, whether we're in Kansas or Virginia or Missouri or South Carolina or beyond. When we use complementary antihypertensive medications together, we lower the blood pressure equally across all diverse demographic groups. And I will show you clear-cut data to support that. That is the foundation of a population-based approach. We'll lower the blood pressure equally in everyone. And of course, there's economic benefits. The faster we lower the blood pressure, the faster we achieve control, the faster we reduce cardiovascular morbidity mortality. It also results in fewer office visits downstream, which then frees up those visits to take care of other individuals that need us. Next slide. So here's an example of how one another can mitigate side effects. If we use a renin-angiotensin system agent inhibitor, such as an ARB or an ACE, with a 1,4-dihydropyridine calcium channel blocker, we reduce the side effects of the calcium channel blocker. We reduce the increase in heart rate that frequently is seen, but more importantly, we reduce significantly the pedal edema, which leads many of our patients to discontinue the calcium channel blocker, such as amlodipine. Next slide. Similarly, if we use a RAS inhibitor, an ARB or an ACE, with a thiazide or thiazide-like diuretic, we also blunt the sympathetic activation of the thiazide, but also more importantly, we blunt the hypokalemia, hyperglycemia, and hyperuricemia of our diuretic, and vice versa. The diuretic blunts the hyperkalemia of the renin-angiotensin system inhibitor. So we get a twofer, if you will, in terms of we lower the doses of each, so that reduces side effects in themselves, but they actually mitigate the side effect profile of each other. So why not use them together from the start? Next slide. I was asked several years ago by the Pan American Health Organization to get together a group to discuss the ideal characteristics of not only single antihypertensive agents, but also the combination of adding two together. What would be the ideal if we had our wishes? And we came up with these, of course, and they're very similar to what we all would come up with if we were asked to do this. And this was published in the Journal of Clinical Hypertension. Clearly, they have to be efficacious. They have to have additive, or better yet, synergistic blood pressure reduction, as we've already mentioned. Clearly, they have to be evidence-based. They should mitigate the side effects of either or both agents. They have to be widely available and affordable and obtainable, I might add. And again, this also is very important. They should be safe and efficacious in a diverse demographic setting, across race, across the ethnicity, sex, geography, salt sensitivity, etc. Once a day formulation would be better and best. And also, if the agents could be in scored tablets, they could be pill split. Some institutions and organizations are doing that now, obviously for economy and savings and ease of supply chain economics. And the patients also can obviously more easily afford their medications. But these are the ideal characteristics of a combination of two agents together. Next slide. So the next question then is, which two? Well, almost all of our guidelines, and I'm going to say all of our guidelines now, recommend that we consider in the initial management of the newly diagnosed hypertensive patient, one of three classes. The diuretics, particularly the thiazide or thiazide-like diuretics, of course. Remember, we're talking about primary care. We're talking about the patient rule, not the exception. Calcium channel blockers, and almost all guidelines would settle on a 1,4-dihydropyridine. Amlodipine seems to be the global pick because of its availability and affordability. And a renin-angiotensin system inhibitor, either an ACE inhibitor or an ARB. And if those are one of the three classes that are in our current guidelines, then we would pick from two of these classes to start a combination medication. So we could pick a RAS inhibitor diuretic. We could pick a RAS inhibitor calcium channel blocker, and any of these permutation and combinations, and you can do them as well as I can. Next slide, Vicki. I put this in here to remind me that notice beta blockers are not here. Beta blockers are not recommended in our current guidelines for the initial management of hypertension. They are reserved, of course, for compelling indications and compelling reasons. So there's plenty of reasons to have an individual with hypertension on a beta blocker, but the initial management of hypertension is not one of them. Next slide. So more recently, I was asked to put together a global group, if you will, including many experts from our country and Europe, in terms of how do we now select an ideal combination dose or combination medications. Well, it's very easy steps. First, select a preferred and acceptable pharmacologic drug classes that you want to use. Second, select preferred and acceptable pharmacologic agents within each drug class that you choose. And finally, you have to get the medication, the patient has to take the medication, select which preferred and acceptable combinations are available and affordable. Next slide. And this is what the group came up with, again, published in the Journal of Clinical Hypertension. And it was in this order. The group looked at the data and preferred a renin-angiotensin aldosterone system, a RAS inhibitor, and a calcium channel blocker as preferred combination in this order. An ARB-CCB combination was number one. Number two was an ACE-CCB combination. The ARB was selected over the ACE inhibitor solely because of tolerability and a much, much better side effect profile, including angioedema and cough. An ARB and thiazide-like diuretic would be third. And against following the same sequence, an ACE and thiazide or thiazide-like diuretic would be fourth. But all of these combinations are acceptable. We did say that the CCB diuretic combination was not preferred, predominantly because there just was not as much evidence-based medicine of this combination in regards to the other four that are mentioned above. Next slide. So remember now, pick an agent within those classes. So if an ARB and CCB combination is going to be preferred, and the ideal characteristics, remember those characteristics, once was once daily formulation, you want long-acting agents. And these are just examples. There's some ARBs that are listed here. Amlodipine is the CCB of choice because globally, it's the most available and it's most affordable, hands down. If an ARB is not available, an ACE inhibitor, CCB combination would be next. Same rules, a long-acting ACE inhibitor, and there are some listed there, and the CCB amlodipine. Similarly, third, an ARB plus a thiazide or thiazide-like diuretic. Chlorthalidone was preferred over hydrochlorothiazide because of its longer half-life. And then similarly and lastly, a long-acting ACE inhibitor and thiazide or thiazide-like diuretic, again, following the same principles. Chlorthalidone would be preferred over hydrochlorothiazide, but all of these combinations of medications are acceptable. Next slide. This is an important slide. And this gets us over clinical or therapeutic administrative inertia. We've talked about clinical therapeutic medications of prescribing medications and intensifying. We want to start the hypertension protocol today. So let's do today's work today and plan tomorrow's work today at the same time. And we propose this stepwise staged approach. Number one, put in place a current protocol of the medications that you immediately have that are available, affordable, and already acceptable. That's step one. If the current protocol is medications that are acceptable, but maybe not ideal, start planning an acceptable protocol, or even better yet, a preferred protocol. And the only difference between these steps are we're moving towards more of the combination medications that have more of the ideal characteristics, if not all of the ideal characteristics that we listed. But the important point is start with a protocol today. Develop a current protocol. Next slide. And this is an example. Here is one current protocol I'm going to show you. It's the protocol that we use here in our internal medicine, low-income clinic, if you will. It starts with a combination of losartan and amlodipine in 2 separate pills at half maximal doses. If the patient's not controlled, you titrate, you double the dose of each. If you're still not controlled, you add hydrochlorothiazide at a half maximal dose. You double that dose to maximal dose if still not controlled, and then you could add a 4th medication or refer the patient from then on. But this is a current protocol. Some of the qualities in here, such as the losartan and the hydrochlorothiazide, do not have all of the ideal characteristics. Their half-lives are shorter, for instance. Next slide. And shown on the other side now is a preferred protocol. And the only difference is, instead of losartan, it starts, and these are only examples, it starts with telmisartan at half maximal dose, 40 milligrams, in a fixed dose combination. Again, but the same principles are the same. Double the dosage. Now they're at maximal. Add chlorthalidone, a longer-acting thiazide-like diuretic. Double the chlorthalidone dose if still not controlled. And again, add a 4th medication or refer to a subspecialist. Next slide. And again, Vicki. And this is an example from Kaiser Permanente, who really started us off on this concept. This is their protocol, and this is obviously Kaiser Permanente in California. Their protocol starts with lisinopril and hydrochlorothiazide, 2 medications initially at once. The doses are increased. Calcium channel blocker is added if blood pressure is not controlled, and a 4th medication is added or referred. There's also a side protocol. If there's pregnancy potential, you don't want to use a RAS inhibitor. And now you can see that a thiazide diuretic and chlorthalidone amlodipine is preferred. Next slide. Again, Vicki. And this shows their data, and it's dramatic. They initiated this algorithm protocol between 2003 and 2004. And you can see as easily as I in blue that prior to the implementation of the protocol and algorithms, using 2 medications as the initial step, their control rates were dismal, less than the national average. Quickly, however, and rapidly, they achieved greater and greater hypertension control rates. Until 2013, they approximated 90%, and this has now been sustained over the last decade. Tremendous success following that the stepwise algorithm approach, but again, with the guiding principles in place. Next slide. And I think this is the most important data that they've published. And that is that this hypertension control rate of almost 90%, between 80 and 90%, is similar across all demographics that they studied. Whether you're non-Hispanic white, you're Hispanic, you're Black, you're Asian Pacific Islander, or other, the hypertension control rates were equal. This is the epitome, this is the embodiment of a population-based approach. Next slide. Well, these are some of the early algorithms, if you will, from the HEARTS in the Americas program. It started with 4 countries. Barbados was the demonstration site. It quickly extended to Chile, Colombia, and Cuba. And now we're well over 22 countries implementing HEARTS, but starting with the standardized protocol. You can see that all 4 countries used 2 medications as the initial step, but you can see that they chose different agents within each class because that's what was available and affordable, some of which had some of the ideal characteristics, but some did not. But that's not what was important. They used and initiated a current protocol while they're planning an acceptable or preferred protocol for the future. Next slide. And this is the results from Barbados. In only 12 to 18 months, you can see that hypertension control rates using their protocol went from a baseline of 50% to a baseline of almost 70%, 66%. It was rapid. And I like to use the cliche, time is outcomes. Yes, we want to achieve a greater hypertension control rate percentage, but the more rapid we achieve that hypertension control rate augmentation, the more rapid we're going to decrease cardiovascular morbidity and mortality, particularly stroke. So time equals outcomes. We want to increase control rates, but we want to do it as rapid as possible. Next slide. And this is in our clinic. Our clinic is inner city here in Columbia, South Carolina. It's obviously a lower socioeconomic group of individuals. As you can see, 80% are Black, 16% are white. Obviously, there's Hispanic and Native American and Asian other individuals. They tend to be older and they tend to be female. Very, very similar demographics to all of our patient population. And most of them are either no pay and or Medicaid and Medicare. Next slide. And here's our protocol that's in place right now. We didn't start with this protocol. We actually started with lisinopril and amlodipine, but we recently moved to losartan and ARB, following those steps, those principles that we already outlined. And presently ours is the same one I've already showed you. It starts with losartan at 50 milligrams and amlodipine at 5, each at half maximal doses. We double the dose within 1 month. If the patient's not controlled, we add hydrochlorothiazide, double that dose. And we also have a protocol where we can add spironolactone and then double the dose and then refer to our hypertension resistant clinic. But this is not a preferred protocol. This is a current protocol. We still are using losartan. We would rather have a longer acting ARB. We are still using hydrochlorothiazide. We would like to have chlorthalidone. And so we are planning that that step, if you will, today, while we've implemented this protocol. Next slide. And our guidelines support exactly what we're doing. Our American Heart Association recommends starting 2 medications when you're exceeding your blood pressure target. Our European colleagues now recommend starting 2 medications at the initial diagnosis step. And more recently, I was very privileged to be on the World Health Organization Guideline Committee, which just published this data, which also recommends starting combination therapy, preferably in a fixed dose combination, but in 2 separate pills where available. Again, pick from 2 of the 3 classes. And again, there's examples in the WHO guidelines that prefer an ARB and a CCB, ACE and a CCB, ARB diuretic, ACE diuretic as such, if you will. So now we have guidelines from WHO, our European colleagues, and our hypertension, our American Heart and Cardiology colleagues in this country urging us to consider this change in our decision making, if you will. Next slide. So let's summarize. So what are the recommendations for developing an algorithm in the treatment of hypertension once we've established that burning platform, that sense of urgency, and once we have had some really, really heart-to-heart discussions on how we're not achieving the goals that we ought to be achieving? Number one, there's some musts. We must include various stakeholders, especially our key primary care leadership in the development. But it's also important to have our subspecialty colleagues involved in the process, even though this is a primary healthcare initiative. It must be simple. Notice there was no branch points on those algorithms. It was linear. The only exception was considering pregnancy. It has to be aimed at the hypertension individual that is cared for not only in the primary care setting, but is the patient rule, not the exception. There's always time for individualized care, as I've already mentioned, and that can be a discussion between us and the patient, and of course, our specialty colleagues when needed. It addresses the clinical barriers of clinical and therapeutic inertia, but must include timely patient care visits too. The WHO guidelines, one of the key recommendations was see the patient back after initiation or titration of medications within 1 month, and they have that, and no longer, so that you can up titrate within 1 month. Use complementary pharmacologic antihypertensive classes of agents, as we've discussed, and use fixed dose combination agents where possible. But if not possible, let's do today's work today and use 2 separate single pills. Next slide, and we're going to conclude. So how are we going to transition from our individualized approach to a population-based treatment approach for hypertension? And again, it's the same rules or same dictums, if you will. We're going to do this by using a standardized, simplified approach to hypertension detection and treatment. We're going to develop it as a primary care-based approach for the patient rule, not the exception. HEARTS in the Americas, including the HEARTS technical package and the E-module that we predominantly discussed today, is a comprehensive blueprint that addresses a spectrum of populations across economic, geographic, racial, ethnic, and cultural diversity. If we're going to do one thing to develop equal care of all of our populations, it's to start with 2 medications, because again, the data shows we control hypertension at equal percentages in everybody. The launch of HEARTS can significantly improve the detection and treatment, and importantly, the control of our hypertension in our state, my state, South Carolina, our 4 states and beyond, as well as in Latin America and the Caribbean, and now globally with the HEARTS global program. And I think this is important. The HEARTS in Americas is in addition to and complementary to programs that are already in place. If we're already doing things well, and it's not broke, don't fix it. But if there's gaps, if there's things we can learn from HEARTS, I believe we should take them, implement them, and put them into programs that are already working, and to use it as a possible fix for programs that aren't. And with that, I thank you very, very much.